really so excited to be joined with Michael today. He's a licensed marriage and family therapist, also certified as a group psychotherapist, so definitely a person close to my heart. Group is my absolute favorite form of therapy. Also certified sex therapist through ASECT. He provides individual group therapy for men concerned about sexual health in Washington, D.C. in his private practice. He also co-authored the book Treating Out of Control Sexual Behavior, Rethinking Sex Addiction in 2016, which is an award-winning book, the Health Professional Book Award. You're also affiliated with the University of Maryland, doing Prevention Research Center, where you conduct capacity building trainings with behavioral health agencies to improve sexual health services and LGBTQ plus cultural competency. So I'm really excited to have you join us today, Michael. And first, I just kind of want to hear your journey. Like, what got you
Sure.
into the counseling field, and then why a specialty in sexuality?
No, that's a great question. Uh, it all primarily started in college, where the subject that was the most appealing to me was psychology, and I just kept pursuing it and was good at it. And I was like, all right, I'm gonna keep going with this. And then as a gay therapist, I was motivated to want to help people of the LGBT community.
Mm.
And then when I first came out as a therapy pup, I started working at an HIV mental health clinic. And it was nestled in an LGBTQ community center. So it kind of brought in the sexual health component that I was really interested in learning and understanding the relationship between sexual health and mental health. So it was a good place to kind of cut my teeth, so to speak. And then within that clinic, I was first working with a population that was feeling out of control sexually as they were coming in, despite having been infected with HIV, saying, I'm having trouble controlling, I'm controlling my sexual behavior. And one would think, like, having been diagnosed with HIV, would that motivate people to start changing their behavior? But they weren't. So I was confused by this because I was a new professional. So I went back into literature, trying to figure out what was going on. That's when I came across sex addiction literature. And I felt that at times it could be pathologizing for sexual diversity. So I was like, this doesn't feel like it fits with the guys that I'm seeing. And then I kept looking for other approaches to help the clients that were coming in my door. And so that was kind of the beginning of it. And then when I became licensed and moved on from that clinic, kind of stayed working in that juncture of mental health, substance abuse, sexual health, both in my private practice work and in my consulting work. It really felt like it was work that was needed. And I was finding that in general, sometimes therapists have a hard time talking about sex and sexuality. So I was like, that's not a problem for me. Let me help these clients. And it ended up working out pretty well for me in that regard.
Wow, so you've worked with some complex areas then, not only mental health, sexual health, and substance use.
Correct.
Like, what has that intersection taught you about the types of things that people struggle with?
A lot. And it really, let me see how I can synthesize this. Part of my approach is to look at the function of the behavior, right? That the sexual behavior is typically, when it's feeling out of control, is a solution to some bind, right? So I want to understand the person as a whole, so I can understand the context in which they're having sex, so I can understand what that function is for them. So it's important for me to understand, are there any pre-existing psychiatric conditions? What is the relationship with drugs and alcohol? How is that relating to their sexual health? And that's really when I started to understand this concept of like developing someone's clinical picture, right? So I can kind of lay it out on the table. Like, these are all the things, these are all the factors that I'm seeing. Like, and this is the sexual behavior that you're concerned about. Let's pair that with your goals for therapy and your kind of vision of overall sexual health. And let's develop a plan that kind of moves you through that clinical picture in a way toward your goals, right? So it's kind of a humanistic, person-centered approach fundamentally, but it was also has this large upfront assessment process where I'm just gathering all this information so I can better understand why they're engaging in this behavior, why they want to stop this behavior, and what other solutions can we start to consider in this process.
I appreciate that approach. It sounds like you take a lot of time to look at all the pieces, all the complexity. And I think
Hmm.
sometimes when I have clients coming in that are struggling with viewing sexual images or pornography, they kind of get stuck on that. Like, that's the thing. And like you
Yes.
mentioned, it's like, oh, let's understand the function of that. It's probably in response to lots of things. And that's going to be very different for people depending on, like you mentioned, the psychiatric history or other
Mhm.
variables in their life or aspects of identity. So I like that you kind of slow that down and say, well, let's see what's going on first before we kind of classify this specific behavior.
Yeah, I mean, and a lot of times people will come with a particular narrative, right? So what I tell people is like, well, let's take a moment and kind of suspend our judgments about what you think is going on, so we can evaluate this narrative. So if they think it's like, oh, I'm coming in, I have this addiction to pornography. It's like, okay, well, tell me what that means to you. What are you trying to say with that phrase? And then let's examine it, right? Let's look at how you're consuming sexual imagery, or how you're masturbating, or how you are trying to achieve some type of sexual pleasure or gratification, and then put it in the context of your overall life, right? And see if that narrative still holds true, right? So I tell people, it's like, this is a collaborative experience, right? We're going to come together and figure this out. And that clinical picture that I talked about is like a shared understanding of their work. But frequently, my clients will come in with addiction language, either I'm a
Yeah,
sex addict or I'm sexually compulsive. Uh, and I think part of the assessment process is just, let's take a moment and slow that down and evaluate it and see if
yeah.
at the end of this, that's still language that feels like is congruent with how you want to see this.
I love that. And that's really similar to my approach that you don't need to really confirm or argue with that kind of
Mm-hmm.
language or narrative. It's like, let's just understand that and see if that is working for you or helpful, or maybe look at another way. And that very is a collaborative approach. And I like
Mm-hmm.
the language you use. Like when I first came across your work, thinking about it as out of control sexual behavior.
Mm-hmm.
I think there's a difference between behavior that's out of control, but also feeling like we're out of control. Could
Correct.
you talk about maybe how those might be different?
Oh, yeah, that's an important distinction, right? And also want to give credit. The phrase "out of control sexual behavior," I think it was first introduced by John Bancroft and a co-author. I never pronounced this correctly, Bogdanovich.
Oh,
Uh,
good old Johns. That's been around a long time then, huh?
Correct. So it was out of an article where he was trying to understand the trying to contribute, I think, to that question around, is this a psychiatric disorder?
Yeah,
So we published this research paper. It didn't provide evidence to support sex addiction as a clinically relevant. And so in his discussion, he was like, we need some placeholder. We need some type
yeah,
of language so we can talk about this without inserting diagnostic sounding language into the discussion. And so he suggested something more descriptive, like out of control sexual
yeah.
behavior. So my colleague and I, who co-wrote the book, Doug Braun Harvey, were like, that's perfect. I was like, we need something to put in this place that is not prematurely labeling someone with a psychiatric disorder. Uh, but when we were writing the book, we're like, but what do we mean by this? I remember it's like, does this phrase have a definition?
Yeah, you guys still have to
Uh,
define that too.
Correct, exactly. I remember we were writing this book, and we're like at my kitchen counter, like, so what do we mean by this? It's like, wait, our title of the book is called Treating Out of Control Sex Behavior. We should probably call it. Like, okay, that's a good idea. So we're like, well, what are we trying to say with this? It's like, well, how I understand it, right? Because when people are coming in saying like, I'm a sex addict or I'm sexually compulsive, I usually hear that as a metaphor, right? That they're saying
Mm,
like, there's something that's happening. I'm feeling like I can't control my sexual behavior, or this, it's happening, and I've had these negative consequences, but I did it again.
yeah,
And, they're trying to explain that contradiction. So I was like, why don't we define it within kind of that subjective experience, right? That what we're trying to say here with this phrase is that they're communicating that something internally feels out of control, either their sexual thoughts, their sexual urges, or their sexual behavior feels out of control.
yeah,
And there's an important distinction. And Marty Klein made this point early on. It's like, just because something feels out of control doesn't necessarily mean it is out of control.
yeah.
Because likely this person is stopping at some point. A lot of times they're going to work. They put the computer away. I know
Hmm.
these are moments where we can get curious around how they are stopping. but there are moments in time where they just feel out of control, that there's something that's happening for them, that this becomes the solution to that bind. And sometimes the results of that are negative, that they don't want, and they're kind of stuck in this pattern. Like, great. I think it's a good placeholder. Like there's something that feels out of control, and then that gives us something to explore and tell us about the times where you feel out of control, times where you don't. How does it stop? How does it start? Like really slowing the process down for people, and without communicating that there's something pathological or disordered about them. And they also understand, like, there's times I might feel out of control regarding my binge TV watching,
right,
or with my relationship with food, or I'm kind of isolating, like, and that just feels out of control as well. So I think people can also understand that concept of times where there's something that doesn't feel right for me, and I want to reach out, get help to understand it more.
yeah, it
And I
is a
don't
lot
need
more.
a disorder to do that.
Yeah, that's a lot more relatable to think about that, and you can think about the different aspects of our life where we feel that way. And I think this is the challenge we've had in the field of mental health, where we need a term to describe this, and we've been like debating terms for so long that
Mm-hmm.
it's really interfered with the development of quality treatments and approaches, because we're stuck on, is it addiction or hypersexual or a
Yep.
compulsion or an impulsion? It's like clearly people are struggling with sexual behaviors. Like we all see that. Now
Mm-hmm.
let's figure out how to help people. And I think we've been stuck on that label for way too long.
Yeah. And the one of the benefits of David Lay's book, Myth of Sex Addiction, I felt like he provided a good analysis and arguments, like how and why this term kind of can fail our clients at times. I was like, okay, so David did all that work. Like Doug and I came, I was like, well, so now what?
Now what?
I
That's
was
the
like,
big question.
yeah.
Now
I was
what?
like, now what? I was like, this isn't a treatment manual. This is just an analysis
Yep.
of this clinical, the proposed disorder. I was like, we still need to help our clients. So
Yes.
they're still coming to my door. And so Doug and I started creating this clinical pathway to help us think critically about how to address this issue, and that became ultimately the outline of the book.
And that's what I want to hear about. So what is your
Sure.
approach? And I think that the thing that stands out to me a lot is I went to school for a long time to learn about mental health, but I got like this much training on sexual health. Like
Sure.
it wasn't even
Yep.
really a focus. It's like, well, that's not a
Mm-hmm.
disorder. Why are we going to work on it? But when I think about people that are struggling with these out of control sexual behaviors, a lot of it is sexual health issues more than something that's necessarily pathological. So I want to hear kind of your framework for healthy sexuality, and then how you begin to help somebody that's struggling with something like pornography.
Perfect. I think there's two good points. I was trying to figure out where to start, and you organized it for me. So let's first start talking about sexual health.
Yeah.
So the definition of sexual health that I use comes out of the World Health Organization's working definition of sexual health, right? And when people hear sexual health, a lot of times they just hear the absence of an STI,
Yeah.
or they hear the absence of an unintended pregnancy, which prior to, like, I think the early to mid 70s, when the World Health Organization started doing this work, that's how we defined and understood sexual health. The absence of, if you didn't have the clap, you were knocked up, you had sexual health, and you're like,
Healthy.
huzzah, perfect, go on to the world. And you're like, the World Health is like, maybe we should probably take a more comprehensive picture or view of this. So that's when they started really trying to understand the complexities of sexual health, that it's also, around somatic and emotionality and relationships and about pleasure. And it's not just trying to avoid infirmity or disease. And then that field kind of moved along, kind of refining their definition. And then there was a call to action in, I think it was the early aughts, with the World Health Organization and the Pan American Health Organization around integrating sexual health as a health domain on par with other health domains like mental
Wow.
health, physical health, spiritual health. And then within it, they were talking about this concept of sexual health and responsibility. And there was a paragraph in there that Doug looked at and he was like, oh, that's interesting. And he just kind of saw some principles that were in there that was like, this seems like a nice framework for helping people develop kind of almost an ethical perspective to think critically about sexual health. Because before, also, we were talking about this concept of sometimes we identify sexual health as in this sex act is good, this sex act is bad,
Right.
or this sex act is healthy, this sex act is unhealthy. And Bill Stanton called that an act-centered approach to sexual health, right?
Oh,
That the sexual act has kind of a moral value that's infused within it. So the meaning that we make around is this is good, this is bad. There's another approach that he identified as like, he called it relationship-centered. We shifted to calling it a principled-centered approach, where it becomes more of an ethical framework to help people think critically about their sexual behaviors, but ultimately to promote their agency in making the choices they want to have, right? So we want to be able to protect their rights to be able to be sexually expressive, but also to protect them from, some type of sexual discrimination, oppression, repression that can even come from the therapist, right?
mm,
So it was like, how do we create a container for both the therapist and the client to think critically? So Doug lifted some of the principles from the PAHO document. It's like, oh, this might be a good way to think about sexual health. So the first one is around consent. Everyone's consenting to be here. Valuing body integrity, people to be able to set boundaries, say yes and say no. The next one is around non-exploitive. So is someone leveraging power and control to have sexual access or gratification over somebody else? It corrodes someone's ability to consent. The next one is one we talked about really early on. It's protected against STIs, HIV, unintended pregnancies. It's still important, but not the totality of sexual health. And then the next one is around honesty. And this is not just honesty with other people about what I like and what I don't like, but it's also interpersonal honesty, like
with
what
yourself.
I like,
Yep.
what I don't like, and kind of a general like openness to sexuality in a way that I can explore and understand it for me. Like what brings me pleasure, what does not bring me pleasure, and then can I communicate that openly and honestly with other people. The next one's around shared values, right? Like sex is all about meaning making. So is this sex act relational? Is it procreational? Is it recreational? And is it existing in that overlap? Or another way I put this is like touch has a lot of different meanings, right? So it's like my elbow touches your shoulder means something completely different if my hand touches your butt. It's still touch. Right. It's just touch, but context matters. We project a lot of this meaning on it, and we have to understand what that meaning is, and then is it shared with the other person or people that you're engaging with? And then lastly, is it mutually pleasurable? Is it pleasurable for me? Is it pleasurable for you or three or whoever is involved in the sex act? And is that something that is understood and valued? So if sexual health or the sexual behavior is happening within that context or in that container, then the details are up to the person. When they start kind of bumping up against one of these principles, this is when, as a therapist, I get a little more involved and get curious about, tell me about this decision. Or have you, finding a way to introduce this concept of exploitation, and then see if that generates any type of internal conflict for my client. Is that aligned with how they want to see themselves as a sexual being, right? And also something we tell people is like, if your sexual behavior is in line with these principles, it's unlikely that your sexual behavior will feel out of control, right? So it also gives them some direction and how to understand it. Because before, they were caught up in that act-centered value system was like, well, looking at porn is bad, or
right
having sex outside of my relation is bad. Exactly. It's like, well, why is it bad?
Yep.
Is it consensual? Is it non-exploitive? And then you kind of tick it through, and they're like, oh, it's because you're not being honest with your sexual partners about what's going on. Well, why don't we talk about that rather than attribute all of the consequences to the particular sex act? Because likely that sex act in another context is probably fine.
Yeah.
But the context in which you are having it is creating all these consequences. And why is that? And it's likely because it's not honoring one of these principles, and it's generating some internal conflict or some external conflict that they're now having to deal with. So that's how I understand sexual health.
Yeah, and that is incredible. Like those 6 principles seem so basic, but it's so comprehensive, and you can bring everything back to those. And as I was thinking about like, okay, yeah, if sexual health is more than the absence of problems, what is it? And I had to search and search, and it came across this model, and it's like, oh yeah, that's it. This is it. Like, where has this been? Like, why don't we all have this framework to make some decisions and think about and reflect on our actions? And we don't. And it's often not until somebody starts to struggle with behaviors that it kind of compels somebody to actually develop a framework. But how
Exactly.
wonderful would it be if, as we're growing up, that we get introduced to a framework like this to help us make good decisions?
Yeah, and I mean that is my hope and what we've been educating on. And I find it like it's helpful for both the clients, right? I think it gives them an ethical framework to evaluate their sexual behavior. It's also helpful for the clinician
Yeah,
to
absolutely.
understand like why am I intervening here?
Oh, I think our video froze for a second.
Okay.
Oh, okay. It looks like we just had a little glitch on the internet, but Michael's back. I was just about ready to call, like, where are you? But you're back, so we're good.
Good, good.
So you're sharing about how
Right.
that framework gives a place for the clinician to kind of organize things and looking for points of intervention to help kind of help them contextualize that behavior in a better picture.
Yeah, because as you mentioned earlier, that we haven't had quality sexual health or sexuality training as clinicians. So many times clinicians, just like people, avoid things that make them uncomfortable. So they won't, so they'll either kind of avoid sexual conversation because they feel uncomfortable, or they might overly respond as a kind of shut it down in a particular way.
Mm.
So I wanted them to have a framework so they can think critically, like, why am I intervening here? So it's not just based on their own feeling of either disgust or discomfort or a kind of a judgment that is morally reprehensible or in that act-centered position, that taking this position of authority, saying this is unhealthy. Uh, I wanted them to have a framework so it's like, all right, I want to intervene, but why? And then kind of tick
Yeah.
through these principles and like, oh, let's focus on the fact that, oh, this is sexual behavior that might be putting them at risk for an unintended pregnancy. It's like, so how do I want to address it? Not just because I'm afraid that they're going to have this consequence or I have judgment about what they're doing. It's more because of that component of sexual health that I want to bring in and help them think critically about.
So it really guides where you go. So thinking about that framework, then how do you apply that to someone who is say, hey, I'm addicted to porn or I'm struggling with
Mm-hmm.
viewing? What would that look like as you're working with somebody?
Sure. Well, it starts from the first session in the consultation. Uh, One of the early questions I ask is what is your vision of sexual health?
Mm.
Because usually they want to come and say, I want to ameliorate this disease.
Yeah.
Like, I want to stop this. All. It's like, okay, that's what you want to stop doing. Where do you want to move towards? What is your
Yeah.
vision? And usually when I say, what is your vision of sexual health? I got this like blank stare back.
It's
Like,
like, what
okay,
do you
what
mean? I
do you
just
mean?
don't want that anymore.
Exactly. Just scoop that out of my brain, please, and put it over there. Like, okay. Um, so when I provide that question, when I ask that question and I get that response back, then it becomes an opportunity to educate them about how I see sexual health. I also see it as part of my informed consent process. So it's like, I want you to know the perspective that I'm working from. So if you agree with me that this is kind of parameters of sexual health that you like, that you would want to move toward, great. If not, then I refer you to another provider. Uh, and it helps them start to think critically about, okay, where do I want to go? Like, why is this important to me? What do I think I would be able to achieve sexually if I just kind of scoop this out of my life, right? Because there's a goal here in mind, and so can I articulate it? So I try to bring in the concept of sexual health right in the beginning, uh, and then once I developed that vision, that gets a little more articulated and clear. It's like, great. It's like, why don't we then go through an assessment process where I gathered all this information from you, develop that clinical picture, and so see we can help you identify some of the factors that are preventing you from achieving that vision.
Mm.
And then we create a sexual health plan based on what we uncover during the assessment process. And the assessment process is usually 4, 6, sometimes 10 sessions where we're just kind of walking through their history. I mean, I have the luxury of doing that in private practice. So we can kind of spend some time with clients and get to know kind of a variety of areas of their lives. But I find it to be a nice, helpful process so I could raise their awareness about what's been going on so they can also see those factors. So when I come at the end and kind of summarize how I understand the clinical picture, none of it is a surprise. They
Yeah.
understand it. And then we can develop a sexual health plan based on what we uncovered or what we found.
And even those words, like, let's develop a sexual health plan, feels like hopeful, empowering,
Yes.
normalizing instead of we need to keep monitoring how much you're viewing and what you're looking at. It's sort of like,
Mm-hmm.
let's focus on the things you shouldn't do. And so you're like, let's focus on the things you want to cultivate. And that really is a
Yeah.
different approach.
Yeah. No, thank you. It's something. I mean, I do also want to say that with the sexual health plan has both. You know, these are some of the things I
Mm,
want to avoid, and these are some of the things I want to do. And how I then set that up is like, great. So if this is something you want to avoid, then it comes from them, right? I don't dictate what should be on their sexual health plan. I also ask them, so we have like an accountability commitment. Like, well, if you cross one of these boundaries, whatever that might be, you're agreeing to let me know the next session, or let the group know the next session. And it's not because I want to like scold them or kick them out of therapy. It's to get curious about what I call this contradiction. Like at some point you wanted to avoid doing this thing, great, but then you did it. Well, that's interesting. That's a contradiction. Let's talk more about that. What happened in those moments that this became a solution to whatever bind you were in, right? So it hopefully elicits some of that conversation and elicits some of the defenses that might be around accountability. So if it takes them 2 or 3 or 4 sessions to tell me or tell group, that's also curious. I was like, well, you made this commitment. Tell me about this contradiction. What was going on that you felt like withholding was the only solution to this bind?
wow.
Because it's likely them bringing in some of the relationship patterns that they are experiencing either in their marriage or at work. They may bring in some of those avoidant defenses that are present, and now they just brought it into therapy. That's great. Let's talk about it. Let's get curious about it. I want to know more about that part of you.
And that seems like such an important pivot. So it's a balanced approach where we're focusing on clearly where you want to go, but also recognizing as you're working on that, you're going to cross some of those boundaries that you've set.
Yeah.
And we need to talk about it. But I think there's a big difference between like, I guess, reporting to be accountable versus sharing to be curious about that, to
Correct.
learn more about that. Because I think whenever we cross a personal boundary, something's going on that we need to understand better. There's a reason
Mm-hmm.
why that is. But often it's like, oh, I just got to
Yeah.
confess that I did it and then I'm going to move on. But it's like, no, 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 this is a learning opportunity. You know, what is there? So I like that. Let's get curious about it. That's
Mm-hmm.
teaching that kind of mindful
Correct.
approach to your life and behavior. There's something to be understood here, and that's okay.
Yeah. And what I a lot of times some shame will come up and
Yeah.
they'll be collecting evidence. It's like, oh, this is just evidence that I am an addict or that
Yep.
I'm an asshole. It's like, no, we don't condemn people for the symptoms that bring them into therapy. I was like,
Yeah.
that is not why we're here. We are here to get curious about what was going on. And I'm glad you brought it in. And then we processed the shame that it took to share this with group or share this with me, because that is also relevant.
Yeah. That's amazing. So there's two areas I want to explore a little bit more because
Yeah.
you've worked with substance abuse and sexual
Mm-hmm.
orientation. I want to
Mm-hmm.
touch on the substance abuse piece because a lot of people view problems around like pornography as similar to substances. And I'm curious your thoughts on to what extent they overlap or what parts may be distinct. How do you see
Mm-hmm.
that?
Well, that's such an interesting question. Just to kind of orient people, like I run a group, I run 2 groups. I run a general OCSB group, or out of control sexual behavior group, for mixed orientation, heterosexual, gay, bisexual men. And then I run a specific sexual health group in recovery, primarily for gay, bisexual men concerned about meth addiction, right? So these are kind of the
Wow.
2 groups
Yeah.
that I run. And I think it's important to remember, you know, there's at times where sex and drug use and alcohol use can get linked,
Yeah.
right? And try to understand, like, why do people use them together, right? And that could be partner sex, that could be solo sex, it could be using sexual imagery, things like that. Usually it's either to amplify the pleasure that they're experiencing or to disinhibit, right? To
Yep.
extinguish some of the things that they're experiencing so they can have some type of sexual pleasure. So I want to understand kind of what the function is for that person again, right? So like, how are these 2 connected? So much of my work is kind of working in that overlap.
Yeah.
But your question was like, how are they kind of individual or kind of distinct? I mean, the primary, if you want to go, the clinical pieces, as you probably already know, is like around, I don't really see the same type of like tolerance and withdrawal symptoms that I see with alcohol or I see with heroin or I see with meth.
Yeah.
Like that piece is different. Not to say that there isn't some type of like emotional fallout that happens if someone is staying up all night, masturbating and looking at sexual imagery. But that to me is not necessarily just because of the imagery. It's like they stayed up all night. I mean, of course you're going to be exhausted and your
Yep.
next day is going to be shot, right? And again, it's like, what are we attributing this to? I'm constantly inviting my clients to evaluate that attribution error, right? Because they
Wow.
make that connection to like, oh, this is because of the porn. I was like, well, how did you come to that conclusion? Like, what is your evidence? Like, my cognitive behavioral background is when I always kind of moves in at this point where I'm trying to help my clients to evaluate their thinking, and how I organize
Yeah.
that is like, I want to see, is it accurate, is it effective, and is it kind? And those are kind of the checklist that I go through. It's like, all right, so you had this attribution. It's like, is it accurate? Is it effective? Is it kind? And kind of walk through it. It's like, how do they absolutely know that this is true? That these emotional fallout is just because of this imagery in front of my eyeball.
Yeah.
Like,
Right.
how is that having that impact? And they many times will see it can be a bit simplistic. It's like, oh yeah, well, that's true. I was up for this amount of time. I wasn't eating. I haven't talked to anybody. You know, like that context does not contribute to my mental health. Like, okay, good. So let's look at it from that perspective. So I'm trying to, again, sometimes like, I call myself a lot of type of therapist, like about me humanistic at times, but also I feel like I'm a narrative therapist because
Yeah.
I'm always helping them evaluate their narrative. And then I have a strong mindfulness background because I want
Yep.
them to be able to slow down and get curious. It's like I'm kind of pulling from all these different directions to help them move forward. So I don't know if that answer is very well contained, but I mean, those are kind of all the ways I look at it. Again, going back to what is the function,
Yep.
and then evaluating what comes back from
That's what
that.
I was going to get back to, is it's back to that function again. And I think our mind, we make so many automatic assumptions and tell ourselves stories and give things so much power. And it's really like, hey,
Mm-hmm.
let's slow down and just examine that a little bit. And I have that same CBT background, but I love that you throw in that and be kind. Like that is something that
Yeah.
sometimes CBT is missed. It's like, yeah, be kind to yourself too, as you're kind of
Yeah.
analyzing how well you're seeing the situation. Because I see like there is a lot of overlap with, because for me, drugs, sex, they're both reinforcers. There's things that are repetitive, things that we enjoy. But so there's a lot of overlapping function, but there are just some distinct things as well. So I
Mm-hmm.
appreciate you walking through that. But again, how we approach them may be kind of similar. Like
It sounds
what's
like it.
going on, what's underlying it, what are your beliefs about it? Even
Yeah.
though the things you're consuming or viewing are different, how we approach it may be very similar.
Correct. Yeah. And I also encourage clinicians that they have to get curious about what it is that the clients are viewing,
Mm,
because I feel like we just you can hear it in my language sometimes. Like I don't always use the word porn. I
yeah,
particularly with clients, I try not to. I talk about sexual imagery, sexual video. The porn can introduce kind of a pejorative and
yep.
kind of shaming attitude around sexual entertainment. But it also it kind of can stop the conversation, and then people assume to know what I'm talking about when I'm talking about I'm looking at porn, right? It's also the same with like when someone says I'm a porn addict or I'm a sex addict, it kind of stops the conversation because like that
Yeah.
becomes the conceptualization that then we're supposed to treat, and curiosity kind of stops,
Yep.
right? Because it communicates some explanatory value in the mind of that person. Uh, so when it comes to sexual imagery, it's like I want to get curious, like, well, tell me the details. What is it that you're looking at? Right? Because that also goes back to the principle. Because first, I want to make sure it's consensual, right? Is everyone who has been recorded of the age of consent or consenting to be there? Because that will shift the direction of the treatment, right? So if this
Mm,
is someone who is minor attracted, I don't work with non-consensual sex, so I want to make sure that I'm getting them to a place where they can receive the most appropriate help, and I will refer them to a non-consensual specialist.
yeah.
Uh, or if they have something that's unconventional, right, that is outside of the mainstream, it's consensual, but it maybe involves a sexual object. Maybe it involves a particular sexual theme around BDSM,
Hmm.
and that changes the context for me because then it makes sense. Like, oh, well, that might contribute to why you're keeping this secretive
Oh,
because
yeah.
you're looking at something that's stigmatized, or you're in a relationship where you haven't communicated your sexual interests with your partner. So it's a way in which you are preserving your eroticism, so it's not extinguished,
Hmm.
and maintain this attachment, right? So again, looking at the function. I won't know that if I don't know the details of what it is that they're looking at. I watched your TED Talk, and
Hmm.
one of the things I really appreciated was the times where you would just slow down in the moment, put your hand on your heart and like really get connected. The the assessment process of gathering this information is just my doorway into that moment. So
Yeah.
when I ask, like, what is it that you're looking at? And then they have this like shame response, then we just slow down. Tell me
Yep.
what just happened. Like, what did you just feel?
Yep.
What words do you have for that? And a lot of times they're either disorganized or they've never really communicated or effectively labeled their emotions. So I was like, get them out of their head. Like, just describe what your body is feeling like.
Yeah.
Is your temperature change? Is your heart rate change?
Yeah.
What are you feeling? And start to get them to be able to mentalize their internal experience. But that all happened because I was moving toward the details of their sexual interests or their sexual behavior. Where a lot of times some of these words that are used just block or
They
stop
do.
the conversation.
Yeah, like as you talk about that, I'm like, man, I could just listen to you all day, Michael. This is wonderful. Because I think you're right on. I think as you just get curious about, like, what is it that you're viewing? It demonstrates so many things. Like, we can explore
Yeah,
this together. This is okay. And as you're walking that path, those emotions are going to come up. And that shame is the bedrock. And that shame seems to perpetuate a lot of these behaviors people are trying to kind of change. And yet often as clinicians, we're like, well, I don't want to feel that. I don't want to go there. But it's like
correct.
that's what we're there for, is to
Correct.
really join in that moment with somebody when they're feeling a tremendous amount of shame, and to be there with them and to care about them.
Yeah.
And it's like that is so much of the healing that we
Psychically.
can offer.
Yeah. It's like hold them psychically, just hold the space
Yeah.
so they can look at this, right?
Yeah.
And not have it be infected by our own discomfort or our own shame and disgust around this behavior. I mean, when I train clinicians, I tell them like to facilitate effective sexual health conversations actually first starts with you
Oh
doing
yeah.
your work and having these conversations with your supervisors, with your peer groups, so you can actually say the words penis or clitoris without
Yep.
blushing, or actually have these conversations. Can I tell you a story?
Oh yeah, let's hear it.
Okay. So when my first therapy client, I was working at a college counseling center. I was a 24-year-old cisgender white heterosexual woman, relationship problems, symptoms of depression. I came into my first psychosocial, I was all proud, and I wrote to my supervisor. I'm like, look, like, a dog with a bone, like flopped it down on her desk. And she read it, and she's like, you didn't ask one question about sex. And like, she's coming for relationship problems, and like, do we know is she orgasmic? Are they having sex? Does she have sex pain? And like, she saw my face, and like, I'm like gay identified, raised Catholic in the suburbs of New Jersey. Like, was not prepared to talk to a woman about sex. And she just saw this happen all across the day. And she's like, she put the paper down. She's like, okay, I want you to say the word clitoris right now 10 times.
Oh
Like,
my
just to
gosh.
like help me work through it. I'm like, oh my God. And so when I tell people, it was like, look at me now, like clitoris, clitoris, clitoris. Like, I can say it. I don't blush. It's fine. But I had to work through that anxiety, so I would stop avoiding this conversation. And when I had the conversation, didn't communicate that this is something to be ashamed of, or that this stigmatized, to be embarrassed about. I actually had to be like straight faced and calm,
Yep.
and welcome this conversation into the room.
That's wonderful. I love that story because I get it. Been there, done that. It's a it's a learning process for us on the other
Yeah.
side of the couch for sure. So
Mm-hmm.
you bring up the other thing that I really want to talk about. So most of the folks I work with that are struggling with pornography are also very religious. And so
Yeah.
I work with a lot of intersecting kind of religious identities and sexual orientation identities.
Yeah.
And the one thing I see that is quite heartbreaking is I work with a lot of folks that are gay, and often in a religious context, they say, oh, I'm same-sex attracted. And often like people in their faith community or helping professionals say, well, let's send you to an addiction group for that.
Yeah.
And they kind of get lumped into, well, this must be a problematic behavior. And it's like, wow, this is an identity piece. This is sexual orientation.
Yeah.
How do you help somebody navigate that that's coming from a religious background and may or may not be viewing sexual images, but they're just kind of lumped into this is a problematic behavior type of a thing? How do you help
Yeah.
somebody in that situation?
Well, I'm glad you brought that piece up. I mean, this is actually one of the reasons why I did not adopt a sex addiction approach, because as I said, going back, when I was researching this issue and I read about the sex addiction model, like, this could easily be used to pathologize gay bisexual men who are struggling with coming out, and it could potentially become a sideways attempt at conversion therapy.
Yeah.
Uh, and so I was like, I'm gonna put this aside and see if I can find another way of understanding this. Uh, and there's a couple ways. I mean, I don't know if I'm gonna have the best answer for you, but how I see this is kind of already kind of hearing in your language is probably similar, but I just see this as identity conflict. That I look at this issue as a concept of competing motivation, right?
Mm.
They have this motivation that comes out of their sexual selves. They have this motivation that comes out of their attachment to their faith community and their identity as a religious person. And these are at odds. And it's ultimately a values conflict. You know, I really like how Grubbs' research has kind of
Yeah.
inserted this concept around moral incongruence, right?
Yep.
So that comes the focus of my work with them. I mean, that research came out right after our book was published, and how Doug and I framed it was as either a sexual or erotic identity conflict, right? So there was a conflict between how they saw themselves, how they wish they were, and who they are, and they're trying to rectify this. I frequently have to disappoint my clients right up front that there's nothing I can do that's going to be able to scoop this out of you. Right?
Yeah.
Doug calls it an erotic ectomy. Like, we're just going to come in there and kind of scoop it out with like a melon baller, and then you no longer be minor attracted, or no longer be same-sex attracted, or no longer be attracted to this particular fetish or
Yeah.
kind of unconventional sexual interest. And so an erotic ectomy. And when
Try
I
not
hear
to
that,
laugh at that, but it's like, oh
no,
gosh.
the humor is helpful, right? At times. So they hear that and they're like, oh, I didn't realize that's what I was asking
Yeah,
for.
that's what they're asking for. It's like, I don't know how
Yeah,
to do that.
yeah. And if I tried, it would probably be more harmful,
Yeah.
right? And it would definitely be ineffective.
Yes.
The last thing I want to do is help you create an adversarial relationship with a part of yourself.
Yep.
Right? And what we know about our erotic selves is we do not want to get into war with it, because we will lose.
Yeah.
It will find a way. It's resilient. And that's also partly how I look at some of these symptoms, as the person preserving a part of their erotic self that may be extinguished in another environment. So I look at it from that strength-based approach. Many times my clients don't want to hear that, and so they may choose not to work with me, and I have to see that as okay, right? But if they are willing to kind of walk and tolerate that with me, then we just try to talk about this bind and kind of find other solutions to managing it. And going back to the sexual health principles, right? A lot of times it's around honesty that keeps popping up, because their primary defense is avoidant or kind of withholding. And can they be okay with what is arousing to them, and then communicate that in whatever relationship they have, and then try to develop relationships around that. Problem is that has particular consequences, right? They could be rejected, they could be excommunicated, could lose marriages, and that might be the consequence of that. So I don't envy them in that bind. Like, that is a difficult situation that they are navigating. And I think partly also being a sexual minority, I can connect with that bind, because I had a similar one to work through. But I also have to manage my own countertransference around kind of being declarative, like, F that,
Yep.
you are who you are, be free, like, we had pride parades for this, like, this is fantastic, like, shout it from the rooftop. I have to manage that, because that's not my goal, right? That's not my vision. They told me what their vision was, and now we have to create a process that fits with their vision. And I've had this conversation with David Lay about this too, because sometimes we'll flick at our approach. It's like, sometimes he feels like it underplays this religious conflict, but I'm also I'm on the coast, right? I don't see the same type of religious
Oh,
community as people in other parts of the country. And I am an out gay man, obviously.
yeah.
So there's a selection bias of who wants to come talk to me. I
Oh, yeah.
still see people who have that moral congruence that is rooted in their faith journey and in their religious upbringing, and I work with them. But it's not as common as I think providers like you see much
Oh, okay.
more on a regular basis.
That's helpful. Yeah, I think I probably spend more of my emotional energy in that space because these are people I really care about that have that conflict where it's like my sexuality is core and my faith is core
Yeah,
and they ain't going anywhere. Like, how do I navigate that? And I think I don't hear as many folks coming in saying, "Hey, I'm gay and I don't want to be anymore. How do I get rid of it? How do I get that erotic ectomy?" I don't
yeah,
hear that
get
as
that out.
much, which is helpful. But I still find that journey to be really challenging because sometimes it's hard to find a place in the LGBT community or the religious community where they can embrace like both sides of a person
Yeah,
and to carve out that space where it's like, yeah, let's find a path that's going to work for you. And it seems like there's just a lot of pressure where it's like, come over here, and it's like, well, let's slow it down so we can find what is really going to make sense for you. And I really appreciate that work, but it's really challenging because we
yeah,
have a lot of strong beliefs about religion and sexuality, and then you throw on things like addiction and this is and isn't okay, and it's like it almost like boxes somebody in, and there's just
yeah,
not a lot of space to figure out where you want to go in your life.
yeah. And sometimes the therapy space is the first space where kind of some of those lines are just cleared out so they can articulate this for the first time.
Yeah.
When I tell my clients, it's like, well, like, first start here. First,
Yep.
be honest here, and then let's see if we can expand it out. And that a lot of times with my clients, the next step is, okay, you're honest with me now. Let's be honest with group and start there, and then slowly build it out. And it can be some slow work.
It's slow and it's so meaningful. I
Yeah,
love it.
agreed. Agreed.
I
I
love
mean,
it.
I tell people like the door that people come to see me is sexual health, but then like once they're in it, it's like the places we go is vast.
Yeah.
But
Yep.
I mean, ultimately, I'm doing like men's work. Like I'm helping men um, identify, label, express their emotions. I'm helping them with intimacy. I'm helping them with intimacy among men. That's non-sexual, and all that to me, I guess, a long way around saying is it's very rewarding work to be
Oh yeah.
doing.
So meaningful. So, Michael, if there's individuals that are trying to navigate their sexual orientation or to navigate struggles with pornography, or clinicians that want to learn more about your approach, how can I direct them to you? What resources would you recommend?
Sure. Well, to find me is probably just my website, michaelvigorito.com. And there's some other resources there, other interviews I've done, links to articles that I've been involved with. Um, I also am now supervising for ASEC sex therapists, which I'm super excited about. So helping
Wow.
shape and mold the mind of future sex therapists, which has been a lot of fun. But yeah, I'm happy to have this conversation with other folks, answer questions. Obviously, more like my book is 400 pages long, so it's a tome. So it's a total mind dump. So everything is there for people. And then there, well, do you want other resources as well? Like kind of what I suggest for my clients to read?
I'm curious about
Is
your
that part
book.
of the question?
Would
Okay.
that be helpful for clinicians and individuals struggling with behaviors, or what's your audience there?
Sure. It is written toward the counselor, but I've had clients come in with the book and are able to weed through some of the kind of clinical jargon and stuff
Okay.
to get something out of it, which is nice. Doug and I are working on a consumer-facing book
Oh,
that will
great.
hopefully be a lot easier for people to read.
Yeah.
Um, so right now, I kind of piece them all together with other kind of consumer books. As, if people are interested in learning more about this issue or how I think about it, and they don't want to sit through a more of a kind of a counseling text, I don't
Wonderful.
blame them.
Well, that's good to know. So if I ever want to go through the ASEC certification process, I'm like, oh, I'll just send you an email. Hey, Michael, I need a mentor. And
Please do. Please do. That'd be fantastic.
that'd be awesome. Well, any final words that you'd want to share with someone who has been struggling with sexual images or pornography or kind of battling kind of that core sexual orientation or self? What would you want to offer them?
The word that just popped up was hope,
Yeah,
right? I think people, when people hear me talking about the kind of the diagnostic problems around sex addiction, sometimes I worry that they think I'm dismissing that this is a problem.
yeah,
And I hope people hear that that is not my approach. I'm just trying to find a way to help them in a way that I feel is more effective. And but what I think happens is people grab for that term because it does give them hope, right?
yeah,
So what I mentioned earlier around how David Lake wrote this book, that was a great analysis of this issue. Part of what we wanted to do is give another process to give people hope that if it's not this, there is another way,
yeah.
right? So this is something that I hope gives people hope that they can achieve their vision of sexual health and have uh, a sex life that feels pleasurable and aligned with their values and feels responsible and fun.
I love it. That feels so good to hear because that's really consistent with my approach with acceptance and commitment therapy,
Mm-hmm.
where it is values based and building that life. And I found it to be really effective in navigating concerns with sexual images and creating space for sexuality in your life. And there is so much hope. There are so many
Yeah,
approaches that can be effective. So I love that. So, Michael,
perfect.
thank you for carving out some time to share your experience and wisdom with us and some of those personal stories. Those were wonderful. Thank you so much, Michael.
You are very welcome. Thank you for the invitation. This was great.